Thank you, Dr. Hussam. This is a Sanofi symposium, and I'm very honored to be invited by Sanofi to present this presentation on clopidogrel in acute coronary syndrome and beyond. Actually, I think that the main message I would like to convey during my presentation is how to face this important challenge while managing patients with acute coronary syndrome. How to make a good balance between the risk of thrombosis and the risk of bleeding. You are now treating a patient with acute coronary syndrome. You want to give him aggressive treatment to prevent any further cardiovascular events or thrombosis in the stent you are putting, but this should not be on the expense of exposing your patient to the risk of bleeding. So this is, I think, is the main challenge that we want to put it as a message in this situation, especially if we keep in mind that bleeding is not a benign condition. And as you can see here from an analysis of the GRACE registry in patients with acute coronary syndrome, they categorized the patients into those who had in-hospital bleeding and those who had no bleeding. And as you can see here, the mortality was quite different, was much higher among patients who suffered from in-hospital bleeding. Of course, the mortality was much higher in the first 20 or 30 days, but the curve kept diverging all over the follow-up period of 6 months. So bleeding is a very much high risk for future cardiovascular events. That's why we are doing our best not to induce bleeding while taking care of our patients with acute coronary syndrome. So I would like to discuss these 3 important points during my presentation to keep this balance in the back of our minds during this discussion, which is the balance. Which dual antiplatelet therapy combination would we use, especially when we are dealing with different types of patients? Patients with acute coronary syndrome, patients with STEMI performing primary PCI, patients with STEMI receiving thrombolytic therapy, or patients requiring oral anticoagulants like patients with atrial fibrillation, completely different story, or chronic stable angina patients having elective PCI, or patients with peripheral arterial disease. We would like to know what are the recommendations in the guidelines nowadays in using dual antiplatelet therapy in such different types of patients. And the second question would be when to start dual antiplatelet therapy, whether to start it very early in the process of management before hospital or during your invasive procedure. This is again very important, and we'd like to see the data and the literature in this regard. And the final point is when would you stop this combination and depend on a monotherapy of antiplatelet therapy? After 6 months, after 1 year, or beyond? Again, this is a hot debatable issue nowadays. Let's start with the first question, which is about the type of drugs we are using in this combination. Of course, aspirin still is the cornerstone and the backbone of any combination in this regard. Aspirin should and is still the main drug to be used with a loading dose of 150 to 300 milligram and a maintenance dose of 75 milligram once daily, and to be kept for life. So this is a class 1 recommendation, no debate about this, and it's still a very important drug in our combination. Until the CURE trial came and we knew that adding an ADP receptor blocker to aspirin will give more protection to our patients. Clopidogrel in patients with acute coronary syndrome, whether treated medically or treated with PCI or even sent to CABG, got more protection with the combination of clopidogrel and aspirin. And this was a landmark trial that proved the importance of the dual antibiotic therapy in patients with acute coronary syndrome. And then there came a more strong drug, a stronger drug, which is the Ticagrelor. And Ticagrelor in the Plato trial was compared to clopidogrel, which was by that time the standard of care in patients with acute coronary syndrome. And we saw further improvement in the protection against cardiovascular events with Ticagrelor. There was a 16% relative risk reduction and the P value was significant. And whether we were treating our patients invasively or even on medical treatment, still there was an advantage of keeping the patient on a more stronger drug than clopidogrel. But this was on the expense or at a cost that we have to pay, which is an increase in the bleeding. This is a stronger drug, a more potent drug, and it's very expected to have increase in bleeding. And in the same Plato trial, there was an increase in the non-CABG type of bleeding with the Ticagrelor compared to the clopidogrel. So you have to keep the balance and be sure that your patient is not at a high risk of bleeding if you decided to give this patient a more strong drug, which is the Ticagrelor. This is just to compare between both drugs in our daily use. This is the Ticagrelor. There are pros, there are cons. It's a rapid and extensive platelet inhibitor drug. It has reversible inhibition with rapid offset of action, so a rapid onset and a rapid offset of action, less susceptible to genetic variation and drug-drug interactions. It reduces ischemic events more than clopidogrel does. It has similar overall bleeding risk versus clopidogrel, although it has a non-CABG bleeding, an increase in the non-CABG bleeding risk with proven efficacy. But on the other hand, it's more expensive. It increases the risk of non-CABG bleeding, and it is given in a twice daily dosing, which is sometimes not very comfortable to the patient with lower compliance, with some side effects like dyspnea and ventricular poses. On the other hand, clopidogrel is affordable drug. It's having a very long history of use in our community, in our patients. It's the only agent with proven efficacy in patients undergoing thrombolytic therapy, and it is easily given once daily. But on the other hand, it has a variable response with sometimes poor response in some of the patients with the susceptible genetic variation, and there are some questions regarding the appropriate dosage of the drug. That's why if a patient is presenting with ST elevation MI, now the guidelines are recommending prasugrel or ticagrelor as the class 1 recommendation, and clopidogrel only if these two drugs are not available. These are patients treated with primary PCI. And in this case, the clopidogrel dose should be 600 milligram orally. But if the patient is treated with thrombolytic therapy, then clopidogrel is the only drug indicated in this situation. There is no mention of ticagrelor or prasugrel in the scenario of thrombolytic therapy, and clopidogrel in this scenario is a class 1A recommendation, and the loading dose is less than the previous case. It's only 300 milligram post thrombolytic therapy. Until we had the TREAT trial, which made a comparison between the ticagrelor and clopidogrel in these patients taking thrombolytic therapy for ST elevation MI. And Ticagrelor proved to be non-inferior with no more bleeding in this regards. So we are waiting whether this single trial will change the guidelines in this regards, patients with ST elevation MI treated with thrombolytic therapy. Another type of high-risk patients is patients with chronic kidney disease, and particularly at end-stage renal disease, it's contraindicated to give Ticagrelor and Prasugrel, not recommended in these patients. And clopidogrel should be your only choice in patients with end-stage renal disease. Another further type of patients with need for anticoagulation, whether this is due to atrial fibrillation or prosthetic valve patients. Now, again, clopidogrel is the only choice. Ticagrelor and Prasugrel are not recommended. They are class 3 recommendation in this regard. So in any triple therapy, clopidogrel is the only drug. And if the patient is at high ischemia risk and a low risk of bleeding, then you can give the triple therapy for six months. But if the patient is a high bleeding risk, then 1 month of triple therapy is enough, and then you can omit one of the antiplatelets, which usually is the aspirin. A further type of patients is the patients with polydisease in the vascular beds, like patients with cerebrovascular disease, patients with peripheral arterial disease. And in this REACH registry, you can see that many patients, not rare, are having more than one affection of the coronary arteries or the cerebrovascular disease or the peripheral arterial disease. And as you can see here, that in patients with cerebrovascular disease, almost a quarter of the patients with cerebrovascular disease will have other affection of peripheral arterial disease or coronary artery disease. And also when patients with peripheral arterial disease, almost 12% of these patients will have other affections of the coronary artery disease or cerebrovascular disease. So these actually are very high risk patients. And we knew from the literature that adding antiplatelet therapy to these patients will prevent cardiovascular complications. And we knew from the Capri trial that clopidogrel in these cases is better than aspirin. It has better outcome if patients with peripheral arterial disease or cerebrovascular disease were given antiplatelet therapy. They had better relative risk reduction in this regard. So clopidogrel is indicated better than aspirin in this regard. And in this trial, we compared clopidogrel versus Ticagrelor in patients with peripheral vascular disease, and as you can see here, there was no difference between Ticagrelor and clopidogrel. Although Ticagrelor will have more bleeding, so the protection is the same. No difference in outcomes between these groups of patients with peripheral arterial disease. So the guidelines now is that if the patient is having lower extremity artery disease, lower limb ischemia, and is symptomatic, then a single antiplatelet therapy is indicated, either aspirin or clopidogrel, and this is a class 1 indication. There is no indication for antiplatelet therapy if the patient is asymptomatic. On the other hand, in patients with carotid artery disease, whether the patient is symptomatic or not, even in asymptomatic patients, still there is an indication. It's a class 2A indication for a single antiplatelet therapy, again, either aspirin or clopidogrel. Of course, when the patient is given stent for the carotid artery, then this is an indication for a combination therapy for 1 month. Now, the second question about when to start the dual antiplatelet therapy. In the Atlantic trial, we have this information that giving the Ticagrelor in the ambulance before reaching the hospital had no further improvement in the pre-PCI coronary reperfusion, no improvement in reperfusion. And in another trial using the clopidogrel and the prasugrel, again, we have seen in this meta-analysis in the ACOS trial that used the prasugrel, in the CREDO, in the CURE that used the clopidogrel, there was no improvement in all-cause mortality if these drugs were given in the ambulance, pre-hospital. No improvement in all-cause mortality. On the other hand, there was an increase in major bleeding. That's why the consensus or the conclusion now that we do not support a strategy of routine pre-treatment in patients with non-ST elevation acute coronary syndrome. We are not giving these antiplatelet therapy in the ambulance, although in Europe they are doing this, but on no clinical basis. Just common sense that the earlier the better, but according to all this data, that there is no advantage of giving the drugs outside the cath lab before the patient reach the hospital. The third and final question in my presentation is when to stop the dual antiplatelet therapy, when to end this combination. And the argument really is strong of continuing the dual antiplatelet therapy for beyond 1 year. As you can see here, this was an elegant study by Greg Stone and his colleagues that followed the patients with acute coronary syndrome by IVUS for 3 years. And he gave us this information that after 3 years of follow-up, 20% of the patients will suffer from a new attack of acute coronary syndrome event. And the great thing about this is that they were able to differentiate that half of the attacks were related to the culprit lesion and another half of the attack were not related to the culprit lesion. Again, this is to emphasize that this is a culprit patient, not a culprit lesion. A vulnerable patient, not a vulnerable lesion. So the patient, again, we have some evidence that the patient is at risk for many years after suffering from an acute attack. And this is just to show you that treating the patient for 30 months with a dual antiplatelet therapy will improve the prognosis of the patient, will reduce the MACE. This is the DAP trial, keeping the patient on thienepyridine drugs for 30 months will reduce the MACE, will reduce the myocardial infarction. Although there was a little bit increase in the all-cause mortality, but we had a MACE reduction and we had myocardial infarction reduction. Good thing, but the bad thing is that this was, again, on the expense of increased risk of bleeding. So there was many studies that worked on the other direction, on reducing the duration of dual antiplatelet therapy to 6 months or even 3 months. These are a list of many trials that compared the short-term versus the longer-term management. And in all these trials and this meta-analysis, there was a reduction in bleeding, as you can see. Almost 35% relative risk reduction in the rate of bleeding when you reduce the duration of dual antiplatelet therapy. And tell you what, there was no increase in the risk of thrombotic cardiovascular events. So reduction in the risk of bleeding and with no increase in the risk of thrombosis or the risk of cardiovascular events in the new era on the new generation of drug-eluting stents. So it's a debatable issue whether to keep the patient for the standard 12 months after acute coronary syndrome, or shorter for 6 months, or even longer for 3 years. What about the guidelines? The guidelines for stable coronary artery disease with elective PCI, the Americans are still sticking to the old duration, 1 month for bare metal stents and 6 months for drug-eluting stents, for the new generation drug-eluting stents, while the European are extending the bare metal stents for 6 months and keeping the drug-eluting stents for 6 months. This is the usual recommendation. For a patient with acute coronary syndrome, not stable, for acute coronary syndrome, of course, 12 months is the standard, especially after PCI, and this is a class 1 indication, 1A indication. And even if the patient was treated medically with thrombolytic therapy with no PCI, still the recommendation is 12 months, although the recommendation is just 2A, not class 1 recommendation, but still it's for 12 months. So what about the 6 months and the 3 years recommendation? The 6 months is indicated for those with high risk of bleeding. If I'm afraid of bleeding complications, I can stop after 6 months the dual antiplatelet therapy and keep him on one antiplatelet like aspirin or others. And this is a class 2A indication. And if the patient is at high risk of thrombotic complications, I'm allowed to extend my dual antiplatelet therapy, and this is a class 2B indication. This is the latest guidelines from the Canadian Society of Cardiology, and they say what? I will give you, after 1 year, a chance to think whether your patient is at a high risk of bleeding or not a high risk of bleeding. If not a high risk of bleeding, then I will continue for 3 years. And they made it universal for all their patients, color in green. That means it's strong recommendation if the patient is not at high risk of bleeding. If the patient is at high risk of bleeding, then 12 months is enough, and then I will continue on clopidogrel alone, or aspirin, of course. Aspirin or clopidogrel after 12 months. So this is a critical period after 1 year. How would you judge whether your patient is at high risk of bleeding or not? You can depend on your clinical sense and see if the patient is, for example, diabetic, if he's having history of myocardial infarction, chronic kidney disease, prior stent thrombosis, or on angio, the patient with multiple stents, with long lesions, with complex lesions like bifurcations or CTO, multi-vessel disease, all these are high risk for thrombotic events. So for these patients, you can extend for 3 years after an acute event. On the other hand, this is the clinical risk factors for bleeding: frailty, anemia, chronic renal failure, low body weight, and given non-steroidals. All of this is indications for high risk of bleeding, so for a shorter time of that. Now we have in the literature, we can depend on scores, not on clinical sense. Either choose the DAPT score or the precise DAPT score. Actually, the DAPT score should be used after 1 year, and it involves this risk factors. And now we have a score of 10, from -2 to 10, and if the patient is getting a score below 2, then this is for a short or standard DAPT. But if the patient is having a score of 2 or more, then you are allowed to continue for 3 years. Like if the patient is in heart failure, vein grafts, acute coronary syndrome, prior MI, all of these scores will be favored for a long duration of DAPT. On the other hand, this is the precise DAPT, and it's mainly for bleeding, and the score is from 0 to 100. And if the score is above 25, then this is a high-risk bleeding. So this is for short duration, 6 months or even less. If the patient is having less than 25, then this is for long or standard dual antiplatelet therapy. So, Mr. Chairman, I will leave you with this take-home message. Bleeding is associated with an adverse prognosis in acute coronary syndrome patients, and all efforts should be made to reduce bleeding whenever possible. Aspirin is still a major component of DAPT. 12 months is still the class 1 recommendation for DAPT in acute coronary syndrome. Clopidogrel is best indicated in elective PCI patients, peripheral arterial disease, STEMI post-thrombotic therapy, on oral anticoagulant therapy, intolerant patients to aspirin monotherapy, end-stage renal disease, and of course, high-risk bleeding. Thank you very, very much for your attention.